Now, there are some other emerging agents too, right? The long-acting carbotegravir, is that what you were referring to? Long-acting drugs?
Yeah, well, yeah, I'm talking about like the issue that we've all kind of danced around and talked about is adherence, and there's you get different opinions from different people, but there's certainly a subset of people that would probably do better if they had a therapy that could be administered infrequently and perhaps under observation.
Okay.
So, and we're moving towards that. Now cabotegravir and rilpivirine are two long-acting agents that can be given by IM shot. The original hope was maybe they would be given as infrequently as once every 3 months. The reality now is it's once a month. So there's the potential for very long-acting formulations that can be implanted and perhaps could last as long as 3 or 6 months. And again, also for prevention. They may actually have a bigger role in prevention because for treatment, you're probably going to need 2 drugs that have a similar half-life, which is twice the challenge. On the other hand, for prevention, this PrEP, if you had a shot that lasted 3 months or an implantable medication that lasted 6 months, the potential for prevention is substantial.
And when we talked about PrEP, we really didn't talk about that being the big limitation of PrEP.
Right.
Is the ability of people to take the pill, even 1 pill a day consistently. So long-acting agent could have a huge advance. And I think the long-acting agents, I mean, cabotegravir and rilpivirine were sort of on the precipice of,
right, sure.
We're in the midst of a registrational trial that, based on the phase 2B study, has a very high chance of success and may have a niche population.
Yeah, I mean, I think it'll succeed in the study. I'm concerned about implementation because the injections are fairly big and cannot be self-administered, at least not as currently formulated. So we'll see how ultimately
And there are these
adapted.
other studies people have heard about, the SWORD 1, SWORD 2 study. What are they?
So SWORD 1, SWORD 2 is a sort of a byproduct of the desire to develop the long-acting formulations, where they found out that you could use these 2 drugs, an integrase inhibitor and an NNRTI rilpivirine, and that they could maintain viral suppression in somebody who's already suppressed.
Okay.
And then with that information, they said, great, now let's move on with the long-acting combination. But by the way, we do have a pretty darn good 1 pill a day integrase, and we have this rilpivirine, and the 2 of them together add up to 75 milligrams of total drug.
So they're small pill, likely very well tolerated, won't matter if you have renal failure or not necessarily. And some people do have problem with pill size. It does make a difference to some people. You know, so it's a potential. We always thought if you were going to use 2 drugs, that one of them should be a boosted protease inhibitor. And the SWORD study, I think, will demonstrate or has demonstrated that it doesn't really have to be that way.
Yeah, I mean, the downside of rilpivirine, as I alluded to earlier, is this interaction with acid-reducing therapies and a requirement that you take it with food for proper absorption. So.
And clearly the advantage here, especially since nukes aren't as big a problem as they used to with the availability of TAF, I mean, I think the big advance here is going to be the pill size. It will be by far the smallest pill.
You know, before we leave, I want to ask something that I think our viewers would like to know. I hope that's something they would like to know, which is it's very technical. We've been throwing names around, names I can't pronounce, and I've been in the business a long time. And yet, there are a lot of folks out there that are going to be HIV positive that are not going to have access to you or you, any of you guys. Where does or can the primary care physician fit in this? Can a primary care doc start this therapy, monitor this therapy, follow on for years? Or is this something that really is inside baseball for you guys? What do you think?
You know, this has become a specialty area, and I don't want to completely lose it, but I also think it's become sufficiently effective and simple and well tolerated that with good advice from a specialist, even if given over the telephone or by email or by advanced telecommunications, a primary care doctor could do it. A primary care doctor who's interested could definitely do this.
They would have to really be invested in it,
Yeah.
and the desire to work with somebody else, because I still find the biggest mistakes I see referred to me are the switch patients, where people really didn't spend a lot of time thinking about what they were doing, simply switch somebody to the wrong regimen. And had they just simply called someone and said, my patient wants this, or I want to give them that, is that okay? They'd have been able to
But wouldn't
do
you
it.
agree, for initial therapy, it's easier to treat HIV than it is to treat
Absolutely.
diabetes or hypertension?
Not just to start, but to be
yeah,
successful.
I think one drug that's on this list of new agents, the bictegravir,
Mm-hmm.
which is very similar. It looks like initially we don't have phase 3 data to dolutegravir, but the issue is it will get co-formulated. In fact, it's going to start out co-formulated with TAF and FTC, so it won't be 2 pills. It'll be 1 pill. It'll be a relatively small pill. I don't know the size of it, but it'll be a relatively small pill. It won't have any of the boosting problems that our current TAF-containing integrase inhibitor has. That's L-vitegravir cobicistat, which is the blocker TAF-FTC. So it's possible that would be it won't have a hepatitis B issue, won't have an HLA-B57 issue, which we didn't even
Cardiovascular,
mention.
yeah.
Probably won't have a cardiovascular issue. So that it potentially could be a therapy that virtually anybody with HIV, with the exception of someone that has a creatinine clearance of 20, could start. And that is the vast majority. So you could be, you could have, for the primary practitioner that's invested, that wants to do it, like Eric said, one starting therapy that you could literally give to everybody.
And even if it's 2 or 3, I mean,
Right.
if they wanted to do it, they could do it.
Diabetes is complicated.
Yes.
Diabetes is hard.
Managed by primary care doctors.
It is, that's my point.
Yeah, so
Doctors can do this.
I am saying,
Not always
I
very
think
well.
I'm married to
I
a primary
think,
care doctor, and she,
You know, the HIV experts
smarter than I am.
at this table, I think, would agree with me. We would all rather have HIV infection than diabetes,
Oh yeah,
You know.
without a doubt.
because HIV is far more easier to manage, requires and much easier to comply to regimen.
And if you take
know,
all your pills, you don't get
works.
complications.
Yeah.
Like
And
diabetes, you
you
can
will-
do everything right and still lose your foot.
Exactly. You know, you
you
will
know,
live for
Yeah.
I
50
mean,
week. You
know,
can
the
start
stigma
on a,
issues. Stigma
you know,
issues are real.
Right,
and
yeah.
so
So
we don't
we're
wanna-
being a little
Yeah.
bit.
We're being flipped,
but-
just to entertain you.
medically, it's
Right,
much
right,
It's true.
easier
right,
to
right.
manage.
Medically, it's easier.
I just want to say, because we're going to wrap this up, that is the single most startling, and I know it's a bit of a hyperbole. The single
it's
most,
not much of a hyperbole.
No, I said a
you
little
know.
bit, but it is the most startling, the most encouraging, the most bright and shining example of medicine that I've heard in the past 20 years.
Yeah, it's
and
pretty
it's astounding that we are sitting here today and doing
We
this.
feel incredibly lucky that we've been part of it.